So good evening, everybody. I am Dr. Deepak from Medanta Hospital. This is the first virtual masterclass which we are organizing on the topic of radio surgery. And the current topic we have chosen is radiobiology of radio surgery in SRS and SBRT. And it is most important topic to understand why we are giving high dose per fraction, what is the benefit. So we have our eminent speaker, Professor Manoj Gupta. He is currently working as a Dean, All India Institute of Medical Sciences, Rishikesh. Sir has more than 100 publications to his name. So without taking much time, I will like to invite Professor Dr. Manoj Gupta to start his talk. Before we start, sir, can we start recording your meeting?
Yes, please. No problem.
And another important thing for the participants, if you have any question, please put on the test box. In the end of meeting, we'll take the question one by one. So please don't unmute yourself. Put your query, whatever is the query, in the text box only. So, sir, please, you can start the meeting.
Okay. Thank you, Deepak, and thanks for having given me this opportunity. And I must congratulate to Dr. Tajinder and her team for starting a virtual meeting on a topic which is, very much in demand these days. And you have designed this program in a very beautiful way that, one topic, one day, one speaker. So it's a kind of teaching program rather than, CME or conference kind of thing. So naturally, speaker is not in hurry to finish the talk. Rather, speaker will be at liberty to, to make the talk simple and to make the audience understand the topic rather than just to rush through the slides. So I must congratulate to whole Medanta team. And now I'm going to share my screen. So let me share my screen. Okay, let me open my presentation. So Deepak, can you see my slides?
Yes, sir, we can see your slide. Yes, sir.
Okay. So naturally, first issue about SRS and SBRT is that what is the rationale why we deliver such a high dose of radiation in a single fraction or maybe in a few fractions like 2 to 5 fractions, while for so many decades we have been practicing fractionated radiotherapy. We have been emphasizing, teaching that fractionated radiotherapy is better and ultimately result into therapeutic gain because the popular 4 hours or 5 hours of radiobiology come into picture during fractionation, and this ultimately lead to therapeutic gain. But now we are delivering just the whole radiation dose in a single fraction. So what is the rationale? What is the radiobiological principle? Now, at the outset, I will say that still we are not able to understand the exact principle of radiobiology in SRS and SBRT, but whatever data we have on experimental animals, from these data we could we could get some lead and some rationale of giving such a high dose of radiation in a single fraction. Now since we deliver the whole dose in a single fraction or a very few number of fractions, so I personally love to call this kind of radiation delivery as non-fractionated radiotherapy. So I will use this terminology more frequently than SRS and SBRT, and the other terminology will be fractionated radiotherapy. This is what we have been doing since ages, that is conventional fractionation radiotherapy. So if you see the to get the best result for non-fractionated radiotherapy, we need to have certain criteria to be met, and these criteria are that there should be small target for non-fractionated radiotherapy, and ideally it has been recommended for a tumor less than 3 centimeter size. Then second, there should be highest degree of conformality. So what does it mean? It means that if you have a spherical tumor, then your high dose cloud should tightly envelop around this spherical tumor. So you should have a highest degree of conformality. The third, there should be steep dose gradient. What does it mean? It means that if you have again a spherical tumor, and if you prescribe at the periphery of the tumor, say 50% isodose line, then outside the periphery, the dose falls very rapidly to the extent that within millimeter outside the target, the dose becomes insignificant. So when it falls outside the target rapidly, the opposite happens inside the target, which means the dose rises from 50% to 100% very rapidly, giving rise to inhomogeneous dose distribution across the target. So that is one of the important characteristic of non-fractionated radiotherapy, that deliberately we create an inhomogeneous dose distribution, unlike fractionated radiotherapy where we want to have a homogeneous dose distribution. Again, to emphasize the same point, that there is a sharp dose gradient across the target. You can see that outside the target within 2 millimeter, dose falls less than half, and inside the target within 2 millimeter, dose rises more than double. So there should be a sharp gradient across the target, outside the target. So that is one of the hallmark of non-fractionated radiotherapy. Now, as I said, there's a teaching program, so I always start with basics. I will just, devote 3-4 slides for, making the audience understand about the cell survival curve. It will be just, refreshing your knowledge of radiobiology, which you already had. There are two processes of cell kill we all know. One is linear and other is quadratic. Now, one process is predominantly seen in low dose region. And what happens that we also know that DNA is the target for radiation to act, and two strands of DNA molecules are the two critical sites which need to be damaged by radiation in order to bring death to the cells. So what happens in low dose region, that as a result of single radiation events, both the critical sites are hit simultaneously, resulting into lethality and cell death. And this type of cell death is known as single hit kill or linear cell kill or alpha cell kill, which is mainly seen in low dose region. Now here the effect is equal to alpha D, where alpha is a constant, and this cell survival curve, because of predominant this process of cell kill, is continuously bending like a shoulder. The other type of cell kill is seen in high dose region. Now here what happens, that as a result of one radiation event, one critical site is hit, causing sublethal damage. Now as a result of second radiation event, other critical site is hit, causing another sublethal damage. And then interaction of these two sublethal damage result into cell death. And this type of cell death is known as double hit kill or quadratic cell kill or beta cell kill. And as I mentioned, it is mainly seen in high dose region. And here the effect is equal to beta D square. And the terminal portion of the cell survival curve is mainly because of predominant this process of cell kill, and it is a straight line. And this kind of explanation is given by linear quadratic model. Now, what is alpha beta ratio? So to understand alpha beta ratio, you need to draw a tangent through the initial curvy portion of the cell survival curve. Now this tangent line will divide the graph into two portions. The upper portion will reflect the cell kill due to linear hit. The lower portion will represent the cell kill due to quadratic hit. Now what I am going to do, I will move from low dose region to high dose region, and we will see how these two processes of cell kill contribute in overall cell kill. So let us start with the low dose region. Now in low dose region, you see all the cell kill is by alpha. When you further increase the dose, still all the cell kill is by alpha. When you further increase the dose, now you will appreciate red arrow start appearing, which means that quadratic hit also contribute in cell kill. When you further increase the dose, the contribution by quadratic hit or beta cell kill keeps increasing. Now at this dose, you will appreciate that height of these two arrows are exactly similar, which means that at this dose, the single hit kill is equal to two hit events or double hit kill. Or we can say that linear hit or linear kill is equal to quadratic kill. And, and linear kill is alpha d. So it is equal to beta d square. Now bring the beta on the left hand side, d on the right hand side, then alpha beta ratio is d square upon d. And when you calculate, it is alpha beta ratio is equal to d. So alpha beta ratio is nothing but the dose at which the two process of cell kill become equal. Now, what happens when you further move towards the dose region? When you further increase the dose, you will appreciate that there is an exponential rise in contribution by quadratic cell kill, while relative contribution by alpha kill is decreasing. So we can say that in low dose region, the predominant process of the cell kill is alpha, and in high dose region, the predominant process of cell kill is beta. We know that based on alpha beta ratio, the normal body tissue have been categorized into two categories. One is late reacting tissue, the other is early reacting tissue. Now these two type of tissue have different shape of cell survival curve. So if you just concentrate on the left panel, then this is the shape of the cell survival curve for late reacting tissue, and here shoulder is more curvy. So again, you draw a tangent into the initial portion or curvy portion of the shoulder and try to find out the dose at which two process of the cell kill become equal. You will appreciate that it is achieved at a low dose. And that is reason that alpha beta ratio for the late reacting tissue are lower. It ranges from 1 gray to 7 gray, and we take an average of 3 gray. Now, if you concentrate on the right panel, it shows the shape of the cell survival curve, and the shape is shoulder is less curvy here. And again, you draw a tangent and try to find out the dose at which two processes of the cell kill become equal. You will appreciate that it is achieved at a higher dose. And that is why the alpha beta ratio for early reacting tissue are higher. It ranges from 6 gray to 15 gray, and we take an average of 10 gray. Interestingly, the malignant tumor behave like an early reacting tumor. So they have an alpha beta ratio similar to alpha beta ratio of early reacting tissue, that is on an average 10, and the shape of the cell survival curve is similar to the shape of early reacting tissue. So with this background, now let us discuss what are the rationale why we deliver high dose of radiation in non-fractionated radiotherapy and how it leads to therapeutic advantage. Now, first, I will try to explain the rationale based on cell survival curve. Now, if you concentrate here on dose region, I have divided the dose region into two. One is low dose region, the other is high dose region. Now, if you see the low dose region, when you deliver 1 gray, it reduces survival fraction to some extent. An increment of 2 gray from 1 to 3 gray further reduces survival fraction. Now, if you concentrate on high dose region, when you deliver 15 gray, it will reduce survival fraction to this point. An increment of 2 gray from 15 to 17 gray will further reduce survival fraction. But you will appreciate that similar increment of 2 gray in high dose region reduces the survival fraction much more as compared to low dose region. So we can say the first principle of non-fractionated radiotherapy is that high dose per fraction is more tumoricidal and is more damaging. I'm sorry. Now, we all know that SRS or the non-fractionated radiotherapy is being used for benign tumor as well. Now, benign tumor, they have low alpha beta ratio. They behave like late reacting tissue. So naturally, they have similar shape of the cell survival curve as late reacting tissue. And as I mentioned, that malignant tumor behave like an early reacting tissue. They have similar shape as early reacting tissue cell survival curve. So in this slide, I will show you that What happens when you increase the dose from D1 to D2 on two types of tumor, that is benign tumor like AVM, meningioma, etc., or malignant tumor. So when you deliver D1 dose, it will reduce survival fraction to both type of tumor. When you increase the dose from D1 to D2, it will further reduce survival fraction in both type of tumor. But again, you will appreciate that reduction in survival fraction for benign tumor is much, much more as compared to malignant tumor. So the another principle is that high dose per fraction is more damaging to benign lesion with low alpha beta value like meningioma, AVM, acoustic neuroma, etc. But same principle will apply in relation to late reacting tissue. So we will question that when you increase the dose from D1 to D2, it will result into more damage for late reacting tissue. And we know that tumor is always surrounded by normal tissue. So when you increase the dose from D1 to D2, it should cause more damage to the surrounding normal tissue for late effect. Answer is yes, it will. Then question is that how we overcome this problem. Now this problem is overcome by highly precise, highly conformal radiotherapy delivery with minimum surrounding normal tissue in high dose clouds. And this principle gives rise to the concept of red shell. So what is red shell? Now, red shell is the thickness or the volume of the normal tissue around the tumor which receive very high dose of radiation. So let us understand the concept of red shell. Now, how do we define our target? We define our target with gross tumor volume. Then we take some margin for microscopic disease and we call it CTV. Then we give further margin for various uncertainties and we call it PTV. But you tell me that does PTV contain any tumor cell? Answer is no, PTV only contains normal cell and we usually prescribe our dose to PTV, which means that normal cells inside the PTV will receive as high dose as GTV or the tumor. So this will form one part of red shell and that is called inner red shell. Now outside this PTV, the dose falls very rapidly as I discussed in my previous slide, but still some volume of the tissue around the PTV will receive high dose of radiation and that will form outer red shell. Now, this is a dip created by careful planning because we do not want this high dose cloud to fall on the serial structure. And when you, just to complete the diagram, when you create a dip on one side, then bulge is created on other side. So this is the concept of red shell. Now we will understand how this red shell affects the two types of radiation delivery, that is fractionated radiotherapy and non-fractionated radiotherapy. First, let us see how this red shell affects the fractionated radiotherapy. Now, fractionated radiotherapy, I have taken a typical example of 70 gray, 35 fraction, 2 gray per fraction. For surrounding normal tissue, we generalize a safe biological effective dose of 100 gray for late effect. And this will be achieved in 60 gray in 30 fraction with 2 gray per fraction. Now, this is the cross section of the dose distribution. So what happens that in the center you have GTV, around the GTV you have CTV, around the CTV you have PTV. And you can appreciate that in fractionated radiotherapy across PTV, the dose distribution is more or less homogeneous. Now, outside this PTV, we have normal tissue. Now, this is the point of tolerance dose, which means that all the normal tissue beyond this point will receive less than 60 gray, which is a safe BED. But intervening tissue between PTV and this point will receive higher dose and they will form red shell. Now this intervening tissue will receive more than 60 gray but less than 70 gray. Now let's just presume that on an average this tissue receives 64 gray and we have planned 35 fractions. So naturally it will be delivered in 35 fraction. and dose per fraction will be 1.8 gray. Now, if you calculate the BED from this formula, putting this value here, the BED of red shell will be around 102 gray, and you can appreciate that 102 gray is almost close to safe BED, that is 100 gray. It is not much higher than the safe BED. So we can say that in fractionated radiotherapy, red shell is there, but the dose which this red shell receive in terms of biological effective dose are almost similar, not very different from safe BED of 100 gray. Now, what happens in non-fractionated radiotherapy? Now, I have taken a typical example of 12 gray 4 times. Now, here also for surrounding normal tissue, safe BED will be same, that is 100 gray for late effect. Now, this time it will be achieved in 29 gray in 4 fraction. This is the cross sections of the dose distribution. So again, if you see in center, we have GTV, then we have CTV, and then we have PTV, and you can appreciate that across PTV, there is a sharp dose gradient resulting into inhomogeneous dose distribution. Surrounding PTV, we have normal tissue. Now, this is the point of tolerance dose, which means that all the normal tissue beyond this point will receive less than 100 grade 3 BED, which is a safe BED. But the intervening tissue will form the red shell, and this tissue will receive more than 29 gray but less than 48 gray. Again, we presume that on an average, it receives 36 gray to be delivered in 4 fraction, 9 gray per fraction. So again, putting this value in biological effective dose formulae, you calculate, it comes out to be 144 gray. And now you will appreciate that this is much, much higher dose as compared to safe BED of 100 gray. So we can say that in non-fractionated radiotherapy, red shell play a very, very important role, and it is very significant in non-fractionated radiotherapy, but not in fractionated radiotherapy. And that is the reason that we should keep the volume or thickness of this red shell as minimum as possible. Then the question is how we can keep the volume of red shell as minimum as possible. There are various ways. One is we should keep the dose gradient very steep, and this is usually done by our medical physicist by careful planning and using non-coplanar beams. Second, keeping the target volume minimum, and that is why the non-fractionated radiotherapy is recommended for early lesions only. Third, reducing the PTV margin. The question is how we can reduce the PTV margin. The answer is simple, that we must use the modern radiotherapy technique like IGRT, 4D radiotherapy, or gamma knife. In my opinion, gamma knife is best to reduce the PTV margin for the simple reason that gamma knife is mainly used for intracranial lesions. We know brain hardly moves inside the bony skull. Bony skull is also fixed stereotactically, and when this whole frame and patient is put inside the gantry, everything is fixed. Nothing moves. The couch does not move, even the radioactive source does not move, and we know that minimum movement, minimum uncertainty. So in my opinion, gamma knife is best for reducing the PT margin. And finally, delivering total dose in more than 1 fraction wherever it is possible, and usually 2 to 4 fractions are recommended. So that is, so till now, I just try to explain the rationale of using non-fractionated radiotherapy based on cell survival curve. Now, I will discuss what are the roles of 4 R's of radiotherapy which are seen in fractionated radiotherapy. These are reoxygenation, repair, repopulation, and redistribution. So what role they play in non-fractionated radiotherapy, and I will discuss one by one. So first, let us discuss about the role of reoxygenation, role of oxygen on cell survival curve. We all know that oxic cells are the most sensitive cell. They have got the steepest cell survival curve. As the oxygen concentration decreases, the cell survival curves become shallower, shallower, and hypoxic cells have the shallowest cell survival curve, and shallowness reflect less sensitivity of cell line to radiation. So in order to reduce the survival fraction to the same point, we have to deliver high dose of radiation if the cells are hypoxic and less dose of radiation when cells are oxic. We also know that, higher the bigger the tumor, more is the hypoxic component and vice versa. So how we overcome the problem of hypoxia? There are two, three ways. One is based on this knowledge that bigger the tumor, more is the hypoxic component. So we try to only treat lesions with non-fractionated radiotherapy, which are small, because the smaller the tumor, they have lesser hypoxic component and they are relatively well oxygenated. But we also know that even there is a minute hypoxic component present in the tumor, it may hamper the radiocurability if whole dose of radiation is delivered in a single fraction, and this is overcome in fractionated radiotherapy by reoxygenation. But how this is overcome in non-fractionated radiotherapy? Again, you will get the answer if you understand the cell survival curve well. Now, if you generate the cell survival curve of mixed population, which contains hypoxic cell as well as oxic cell, so how it will look? So initially, the initial portion of the cell survival curve will reflect the reduction in survival fraction of oxic cells because they are more sensitive. Had there not been any hypoxia component, the cell survival curve would have ended like this. But since hypoxic cells are also there, which are relatively radio resistant, so the survival curve becomes shallower. And this belongs to hypoxic cells. So there is a transition from oxic cell survival curve to hypoxic cell survival curve, and this is called hypoxic transitional zone, and it is usually achieved at a higher dose of 10 gray. Now what happens if you give fractionated radiotherapy? You deliver 2 gray per fraction, and it will only kill oxic cell. There is no effect on hypoxic cell. But during fractionation, some of the cells in hypoxic compartment will move on to oxic compartment and will become sensitive. In non-fractionated radiotherapy, you deliver very high dose of radiation, say 12 gray. Now 12 gray not only will depopulate the oxic cell, but also depopulate the hypoxic cell. So there is a direct damaging effect of high dose of radiation delivered in non-fractionated radiotherapy on hypoxic cells. And this is the second method by which we overcome the problem of hypoxia in non-fractionated radiotherapy. This can also be understood from oxygen enhancement ratio. We all understand what is OER. It is basically the dose of radiation for hypoxia versus aerobic cells, which is delivered to get the same tumor control or to reduce the survival fraction to same point. Now it is 2.5 to 3 for X-rays, which means that you need to deliver 3 times higher dose for hypoxic cell as compared to oxic cell. D0 for aerobic we know is around 2 gray. So for D0 hypoxic, it should be 6 gray. And in non-fractionated radiotherapy, how much we deliver? Usually more than 12 gray. So from here also you can appreciate that this dose will have a direct damaging effect on hypoxic cell. Now, vascular damage, the third method by which the problem of hypoxia is overcome in non-fractionated radiotherapy. Now, vascular damage I will discuss in in more detail later on, but I want to show you that how vascular damage result ultimately in overcoming the problem of hypoxia. Now, we all know that the tumor sheet tumor cells grow in a in a sheet around the blood vessels. So it has been seen that when you deliver very high dose of radiation, like in non-fractionated radiotherapy, it will occlude the blood vessel. It will damage the blood vessel. Now, this capillary is supplying this large number of tumor cells. Now, tumor cells which are nearer to the capillary are oxic, which are away from the capillary are hypoxic. So there is a divide line. The cells which are nearer to the blood vessels are oxic, away from blood vessels are hypoxic. So what happens when you deliver high dose of radiation, it will cause damage to this blood vessel. So there will not be any supply. So this will not only kill oxic cell, but also hypoxic cell. So hypoxic cell will be damaged because of this reason as well. So these are the 2-3 methods by which we overcome, or we can explain how we overcome the problem of hypoxia in a tumor when we treat them with non-fractionated radiotherapy.